Hello everyone, I'm Dr. Donna Woodhouse. I am a senior lecturer at Sheffield Hallam University in the UK. Before I begin my presentation, I'd just like to thank the conference organisers for their good communication and support through this process. I've been involved in a couple of conferences myself, organising them. It's incredibly hard work, and I can't imagine how difficult it became for the organisers in terms of the pandemic. So thank you, and I look forward to seeing you next year. The presentation today, I'm going to look at a programme called Active for Health, which I evaluated with a number of colleagues. At the end of the presentation, there'll be a slide with my contact details. So if you'd like a copy of the full report that the presentation is based on, then please let me know and I'll get back to you as soon as I can. Also, one of the reasons I like this conference so much is that it's multidisciplinary. So I will be using some acronyms, some terminology and some abbreviations that some people may not be familiar with. So again, at the end of the presentation, there's a slide which details all of those, which I hope you'll find helpful. So as I say, the programme we were looking at is called Active for Health. The university that I work at, as a lot of universities do nowadays, has some quite grand mission statements. One of them is that we like to create knowledge. We're very much an applied university, and whilst we do work locally, we also do work nationally and internationally, and hence one of the reasons that I'm presenting today. For those of you unfamiliar with Sheffield, which may well be most of you, it's in the north of England. It was the UK's first city of sport. We have a number of professional sports teams here, and we're fortunate enough to be very close to the Peak District National Park. So we have lots of climbing, mountain biking, walking and running, lots of nice green space, as well as urban city sports facilities. The area that the research took place in is Rotherham, which is a smaller conurbation just to the east of Sheffield. Now, the context of Rotherham is that it's one of the most deprived districts, councils, unitary authorities in England. Life expectancy for males and females is lower than the national average. And some of the conditions that we're looking at here include cancer, hip fracture and cardiovascular conditions, which again are higher than the national average, whereas the number of people engaging in physical activity is lower than the national average. So here we're looking at long-term conditions, so conditions which can't be cured, but they can be managed, perhaps via medication, but also via therapy, and very much what we're looking at here, some lifestyle modification. So in the UK, the aim is that adults participate in 150 minutes of moderate physical activity per week, plus strength exercises a couple of times a week as well, but only 1 in 5 people with long-term health conditions hit those targets. There is some evidence that if we integrate physical activity into the disease management pathways, that will help people to recover, but there isn't very much in the way of evidence of how that might best be achieved. So we're looking with Active for Health very much at integrating physical activity as part of rehab, but also very importantly, trying to encourage adherence so that that activity is sustained and becomes part of a healthier, longer term lifestyle. So what we're trying to do here is give participants skills and, very importantly, confidence about exercising, giving people the ability to self-manage their condition and exercise as well. So as I say again, it's not just about a 12-week HIT, which is the length of the programme. It's about trying to encourage people to develop a longer term commitment to physical activity. So the programme itself is funded by Sport England, and it's looking at 7 long-term conditions, including, as I've mentioned before, cancer, but also musculoskeletal issues, COPD. Both Sheffield and Rotherham are very much from a heavy industry base, historically coal and steel. Again, just to reiterate, what we're looking at here is a 12-week programme, but very much with a view to maintaining activity and improving health longer term. So here I've just kind of diagrammed this up, that essentially it's a rehab programme which gets health professionals to identify suitable patients who then participate in this 12-week programme, which is led by exercise professionals. And then as they leave that programme, measures are put in place so that that exercise can continue without the assistance of those exercise professionals. Now, I don't particularly like the term wicked issues, but it is fairly common parlance for some people in terms of looking at things like illness and social deprivation, where essentially you have a number of factors that contribute to significant social issues. So if you have complex problems, then the solution to those problems doesn't lie with any one individual, with any agency, or even with any sector. So our take is that we also need multidisciplinary research. So we'll look at some of the economic findings a little later. Also, some of my colleagues work in health, some are psychologists, and I'm very much a sociologist interested in the kind of qualitative aspects of research. So we have one of our research centres. We have people like myself who are research active teaching staff. We also have the National Centre for Sport and Exercise Medicine, which is one of our 2012 Olympic Legacy projects, and a local project called Move More, which aims to get Sheffield as a city generally being more physically active. Rotherham Council commissioned the Exercise Science Centre to evaluate the project. So we did some financial modelling. We interviewed both health and fitness professionals at baseline and then 2 other points. And obviously we also interviewed participants, again at certain key points, looking at quality of life, looking at levels of physical activity, and also using patient activation measures. The sample there is approximately 1,100, slightly more females than males, a predominantly white cohort with a mean age of a touch over 65. You can see here that there is a high attrition rate, which we acknowledge is an issue. But over the course of the project, we interviewed people across all of the 7 pathways. As I say, there is high attrition. This is very much commissioned research from a local authority. We didn't have a control group, and obviously there's the potential to have a self-selection bias here. Very important for our colleagues who commission projects, the cost of this project is £105 per participant. So we measured the patient's usual use of NHS, of health services, and how much that would cost. And we see that over a year here, there's a saving per participant of around £850. So the financial saving here is very significant indeed. We also looked at patient activation. And the idea that as a patient, the more active you are, the more aware you are of your own condition and symptoms, the more likely you are to be able to manage your condition successfully. And what we found is across those 7 long-term health conditions, there were different levels of patient activation. So patients with cancer and musculoskeletal issues were more activated. The least activated patients were those recovering from stroke, who saw other people as having more responsibility for their recovery. But all the patients spoke about the physical, social, or psychological benefits of their participation in the programme. There were increases in physical activity, accompanied by improvements in quality of life scores. And you see some of the statistics there. The amount of work time lost to sickness was reduced, and the levels of activity, moderate to vigorous every week, increased. So that's good news. Quality of life rose most when there was maximum support from professionals present. And as the professionals then backed away and people became more independent, then that dipped. But the figures were still higher than baseline. Unfortunately, whilst people did report that they were able to participate in more activities and had less pain, there was no improvement in people's ability overall to perform self-care activities. As I say, my background is in qualitative research, so here we've done a thematic analysis of some of our interview data. And one of the things that participants really appreciated about the programme was its very personalised nature. So the individual patients were pushed if they were happy to do that. Not everyone had to move along at the same pace, so people who were a little more reticent build their participation more gradually. So this idea of adapting the programme for people. Also, the idea of trust came through as being very important. Obviously, some people, you'll have had this perhaps yourself, if you've had an injury, and you can be quite tentative about returning to training or physical activity. But here the instructors are pushing but being supportive, and again this idea of gradual progression, which participants liked. Trust, again, motivation is tied to this, that if you were trying to exercise on your own at home or in a gym, perhaps you would go, I don't want to do that, that might be painful, that might worsen my condition. But we have here somebody in one of our cancer cohorts talking about the idea of lifestyle, that they saw the exercise not as medicinal and as part of their treatment, but as something that was enjoyable and supportive. Patients, again, really enjoyed the social aspect of these programs, that they were together with like-minded people, people who'd been through what they'd been through. So there was a common language and an ability to socialise and kind of have a coffee afterwards as well, and a chat. So it was a nice space for patients who sometimes told us they didn't want to burden their relatives continually by talking about their illness. So that social component may have contributed to an enhanced quality of life score, but it didn't seem to encourage adherence beyond the programme. I've mentioned the attrition rate there. Some people left because they went back to work, or they felt confident enough to engage in physical activity themselves. Some people, unfortunately, their health declined, and some people said that the timing or the location of the session wasn't convenient for them. I'm going to look in a little while at recommendations that we'd make to people who are establishing similar programs, but there's a real need for consistency. And participants told us that they found it difficult to adapt to a change of personnel. So fitness professionals who may have a different style or tone. We also would encourage project managers to really emphasize the expertise and the high level of qualifications of fitness instructors as well. And also for healthcare professionals to address patient fears at the outset, that exercise can be a positive, exercise won't make you feel worse, won't likely lead to more injury. So the people who stuck with the program had high levels of activation. They enjoyed the delivery format, and they really did value the opportunity to have social interaction. We noted that a number of participants had engaged in physical activity earlier in life, or before they became unwell. So here it might be important to remember that we're re-engaging people in physical activity rather than engaging them. Sorry, that's me forgetting to turn my phone off, which is very clumsy of me, but now it's gone. What we were trying to achieve was a change in physical activity pattern, and certainly a number of participants subsequently involved in, say, regular walking, a cheap, accessible means of physical activity. Something that we did recommend is that there was improved communication between healthcare professionals and exercise staff, and also between healthcare professionals, so that there's a uniformity of decision making around which patient is suitable or not suitable. We would also recommend that healthcare professionals are all highly qualified, what would be in the UK a level 4 qualification, because they're working with patients who have complex health needs. They need to be confident, the patients need to be confident, and the healthcare professionals need to be confident too. And also building on the idea that social interaction was valued, perhaps in terms of encouraging longer term commitment to physical activity. We could draw on research which demonstrates that you're more likely to keep exercising if you have an exercise buddy to help to motivate you. So that has been something of a gallop through what was a very lengthy piece of research. As I say, we have the abbreviations here, which some of you will be familiar with, so forgive me for that, but some colleagues may not be as familiar. This is commissioned research, but obviously it is based on sound academic principles and recognised literature, and so I've just pop those here for people so that you can flick back to slides and see the kind of lit that we were using. My contact details are there, so if you do want the full report, get in touch with me. I'm the kind of contact for this, but obviously I've listed colleagues who participated in the research too. If you're interested in Move More, which, as I say, is about getting an entire city to become more physically active, then you can get in touch with the Move More guys there. Or if you're interested, we have 3 national centres for sport and exercise medicine in the UK, and we're very happy to have one of those in Sheffield, so you can look at their work. Or if you're interested more broadly in the work of Sheffield Hallam in terms of sport and health, the college that we're based in isn't just about sport, it's about health, well-being and life sciences. Just again to thank the conference organisers. I hope that you've found some merit in this presentation, and if you want more detail, do get in touch. But until I see you next, be well, keep safe. Thank you.